I'm Ali Calder. I'm a radiologist at Great Ormond Street in London. My special interest is actually bones and lungs. So I'm talking about the acute abdomen today, which is of interest to all paediatric radiologists because it's what brings us into hospital on call and in the middle of the night. So that's what we'll focus on. No relevant conflict of interests. There are a lot of things I could talk about. I'm going to try and focus on three common conditions: pyloric stenosis, intussusception, and acute appendicitis. There just isn't time to cover anything else, I'm afraid. So starting with pyloric stenosis, ultrasound has been used to demonstrate pyloric stenosis for a long time. This is probably the earliest paper by the great Rita Teal, who I actually met as a medical student a long time ago. I was the medical student, not Rita. And this is actually an ultrasound image in the paper, believe it or not. Thank God for progress, because I'm not sure I could interpret these images. Within a decade of that paper, ultrasound was becoming routine in the diagnosis of pyloric stenosis, but some surgeons weren't happy. This anonymous surgeon wrote a letter, an editorial in The Lancet, saying that most of the enthusiasm for ultrasound diagnosis was generated by radiologists in their endeavour to make diagnoses, I suppose, and that there was little critical appraisal of the actual need for the imaging. And he reflected that the trend towards routine ultrasound in pyloric stenosis should be resisted. Well, unfortunately, resistance is useless, as you can see that ultrasound has become routine in most cases of pyloric stenosis. I don't know many surgeons now who will go to theatre without an ultrasound. So there's a good reason for this, and that's because ultrasound for pyloric stenosis is an excellent test. We're not often able to say this, but several papers have shown perfect diagnostic accuracy for ultrasound. Very few report anything less than 95% sensitivity or specificity, most higher, and using various parameters as well as the overall assessment. And that includes ultrasounds done by surgeons as well as by radiologists. So it obviously doesn't require huge technical skill. So some questions to ask the literature. Is ultrasound actually always necessary? Should it be routine? When you're doing the ultrasound, what are the best criteria? And so on. How do we apply those in different patients? So is ultrasound always necessary? Well, no one's addressed this for a long time. These papers are over 20 years old. But you'll see that actually these was clinical examinations by experienced paediatric surgeons had a very almost negligible false negative rate. So if a surgeon makes the clinical findings is the child with bilious vomiting, often with visible hyperperistalsis of the stomach and a palpable olive-shaped lump in the right upper quadrant, is actually a reliable sign. But it's not always present, and you can see quite a number of false negatives. So I think if you have an experienced surgeon who is taking patients straight to theatre, they're probably getting the diagnosis right. You shouldn't be too worried. I have to say, that's not most people's experience nowadays. How to do the ultrasound? It's fairly straightforward. When pyloric stenosis is present, you'll put the probe on and it will be there most of the time. These days you should be using a linear probe in a sector scanning mode, and you can use quite a high resolution. You can get some beautiful pictures. To find the pylorus, I think the hardest ones are where the pylorus is normal, because it's a harder thing to find when it's not massively enlarged. Look for the gallbladder, look medial to the gallbladder, there it is. What you may find, particularly if the child's crying and the stomach is full of gas, is that you can't see much. If that's the case, turn the child right side down, and then the fluid in the stomach will act as an acoustic window. They've usually got an NG tube down and an empty stomach, and you can put a little bit of water in, and often water's a better acoustic window than curdled milk. There's one downside to turning the child towards you when they're vomiting, which I needn't really go into much detail. Once you've found the pylorus, watch it, take lots of pictures. Simples. So a lot of radiologists think the radiologist with a ruler is a radiologist in trouble, but I think measurement in this condition is quite important. There are various parameters you can measure: the thickness of the muscle coat, the overall diameter of the pylorus in the transverse section, or the length of the canal. This paper would suggest that all of these have their merits, although that the pyloric diameter in this paper there was quite a bit of overlap between the normal range and the pathological range. This And another paper, a similar study, had a slightly different result showing that there was more overlap with the canal length. Generally, though, I think the most consistently useful finding is the pyloric muscle thickness, and a cutoff of 3 millimeters works pretty well. You can also use a pyloric muscle length of about 17 millimeters as a cutoff. People will sometimes say 16 or 15. You can look at the morphology of the pylorus as well. You have this hypertrophied mass, and the shape of the pylorus makes with the fluid in the stomach can be quite interesting. There's often hypertrophic mucosa that bulges into the fluid in the stomach and looks like a nipple. And sometimes when you have the shouldered appearance of the muscle, can very much resemble the cervix as well. And those are just ways of describing what we all recognize. There have been attempts to validate other tests, which I'm not sure are really necessary since this is usually a straightforward ultrasound diagnosis, but you will see hypervascularity in the muscle coat. People have Dopplered the jets of fluid going through the canal. I don't think necessary, to be honest. You will hear some people say, oh, you must watch the pylorus for several minutes because it might open. I think if you're dealing with a borderline case, that's sensible. If the measurements don't quite meet the criteria, because it may just be some pylorospasm. But be wary that a little bit of fluid traveling through the pylorus is normal. In pyloric stenosis, I should say. And we know that because before we had ultrasound, we did barium, and that depended on fluid going through the pylorus. This is not a complete obstruction, so don't be persuaded away from the correct diagnosis. There's no real evidence that sort of prolonged examination adds to the already excellent diagnostic accuracy. One question that's often asked is, well, we're typically used to seeing this at 2 to 8 weeks of age, but occasionally you see it in the immediate neonatal period, and also you may see it in small ex-preterm babies. And then the question arises, do the criteria still apply? Well, the simple answer is by and large yes. This paper, where they studied a large number of kids with pyloric stenosis, identified 3 preterm babies who, on their initial ultrasound, had a pyloric muscle thickness of less than 2.5, so wouldn't meet the criteria, but actually on delayed ultrasound were shown to have pyloric stenosis. Another study that looked at the relationship between the size of patients did show that there was a relationship between the thickness and the length with the size of the patient, but that didn't really affect the diagnostic effectiveness of ultrasound, which in this paper was near perfect. Interestingly, in this study, in the small print, actually 3 patients did have a thickness less than 3 millimeters, but when they were followed up, they grew to above 3 millimeters. So, summarizing pyloric stenosis, don't worry if a good surgeon is taking patients straight to theatre if they know what they're doing. Use the pyloric muscle thickness as the best criterion, and it's a reliable indicator. You only need to if the findings are equivocal, or if there's a strong suspicion but the first scan is negative, always suggest a follow-up scan. I tend to say 48 hours, 24 if they're worsening. It does no harm. Okay, moving on to intussusception. I'm going to ask similar questions about the diagnostic accuracy of ultrasound and perhaps where you can go wrong with ultrasound. I'm also going to talk about using ultrasound to predict outcome and then talk about reduction methods and the evidence base for them. Like pyloric stenosis, ultrasound is an excellent test. It's a really strong test, very high accuracy rates. And actually, there are a lot of papers with similar figures, and that regardless of who does the ultrasound. So again, we have high sensitivity and specificity both with specialized sonographers, mixed radiology populations, but also non-radiological staff. The last bottom paper there, emergency department physicians performing ultrasounds with very high accuracy. Not that I recommend that. I want to just talk to you quickly about how to think about intussusception in terms of what the imaging shows. We might talk to our families, say, oh, well, it's a bit like a sock going in on itself, but we know that's not really what's going on, because the sock has a mesentery with blood vessels and lymph nodes within it. And all of that is what makes up the contents of the intussusception, not just bowel in bowel. And that's important. And that's what you end up with, as my daughter is demonstrating. So, things where you can go wrong with false positives. Most of the false positives are not really false positives, but it's just a purely small bowel intussusception. Every now and then you'll see something else, and I'll show you some examples. Small bowel intussusception, I think we sometimes worry about. This was a nice paper in radiology showing that generally they can be distinguished based on size, particularly not so much the overall size, but the size of the mesenteric contents of the intussusception. And when that, what they call the fat core, was less than 6 millimeters thick, it was a small bowel only intussusception. I think that's quite a useful sign. You'll much more often see lymph nodes as well within the ileocolic reducible intussusceptions. This was a recent pair of papers on small bowel only intussusceptions. The paper on the left, they described almost 140 patients with small bowel intussusception, and actually 18 underwent surgery, and they did identify mostly CT findings that were predictors for surgery. One, I think, particularly useful thing from an imaging point of view was that a very long small bowel intussusception usually needed an operation. I think the other paper is slightly misleading because they only included patients with transient small bowel intussusception. Not surprisingly, none of them needed surgery. You can overcall bowel wall thickening as intussusception, particularly when there's echogenic bowel contents. It can be confusing. The child may have a condition like a Henoch-Schönlein purpura or something causing bowel wall thickening. And of course, children with bowel wall thickening are also at risk of intussusception, which may be intermittent. So don't be too critical of yourself if you get that wrong. This is one that we all fell for in my hospital. This was a child after a bone marrow transplant with severe systemic adenovirus infection, including a colitis, and he had massive hemorrhage into his gut. The echogenic hemorrhage really persuaded us that this was an intussusception. Because his gut was thought to be very friable, we didn't perform an enema. He went to theatre, and they took out an enormous blood clot, but there was no intussusception. False negatives are very rare. This is the only one I came across. The child had a negative ultrasound done by a trainee overnight, and in the morning the intussusception appeared outside the patient's bottom. When we did the ultrasound, the reason it had been missed is we hadn't scanned the pelvis. So remember to scan the whole abdomen. An ileocolic intussusception can come all the way. In fact, I've seen one prolapsing intussusception that was easily reducible on 80 millimeters of mercury with air. So don't think that means they can't be reduced. What about the abdominal film, sort of traditional approach to diagnosing intussusception? Well, I'm not a fan. This is a paper where they went to a lot of effort to try and identify intussusceptions just with plain films, and they performed triple abdominal radiographs in supine, prone, and lateral decubitus positions. And if there was no gas in the right side of the bowel on one of those views, they said that was intussusception. And they got very impressive sensitivity of 100%, but that's essentially because it was always positive, and the specificity was useless. So I don't think that's a valuable approach. Some people will say, well, you need to do the abdominal film because you need to identify pneumoperitoneum. But I think pneumoperitoneum in intussusception prior to treatment is extremely rare, even when there is a perforation, because, of course, the perforation is contained by the intussusception, so there's not free gas. And it is, in fact, very rarely described. This paper looked at a large number of abdominal films. Nothing on the abdominal film was helpful in predicting outcome, and the only two that had a pneumoperitoneum had barn door peritonitis and needed an operation in any case. There was no unexpected pneumoperitoneum found. You can use some imaging markers to try and predict how your enema or whatever reduction method you're going to do is going to go. A couple of papers that I think have sort of sunk into the folklore of pediatric radiology. This first one I think is a very valuable sign. Trapped peritoneal fluid is a strong indicator that you're not going to win. You've got probably a substantially less than 50% chance of reducing an intussusception with trapped fluid. That's not to say you wouldn't have a try, and partial reduction can help the surgeon. Another approach has been to look at colour flow, and this paper, on which a lot of practice has been based, showed that in the 3 with reduced blood flow, none of them are reducible. Numbers here are very small, and I think modern ultrasound is so different. I think sometimes when technology gets better, it doesn't make our lives easier, it makes it harder, because instead of having an absolute there is or there isn't blood flow, we now have a spectrum. And deciding where a patient is on that spectrum can be challenging. Our own audit experience has shown that actually when we've detected reduced blood flow, reduction has actually been easier. So I'm not sure how useful that is as a sign. There have been several other papers addressing other predictors of outcome. Again, this paper at the top, trapped fluid, only 2 out of 14 with trapped fluid were reducible. Bowel obstruction as well seems to be an adverse sign, although again there's a reasonable chance of success and you should go ahead. There are variable results on whether wall thickening on the ultrasound is helpful. The top paper says no. The bottom paper says yes, that's a bad sign when it's very thickened, over 14 millimeters. And a recent paper looking at hydrostatic reduction showed that the location of the mass on ultrasound, if it was in the left side of the abdomen, it was less reducible than if it was in the right, was a very significant indicator of failure. So how to reduce the intussusception? Well, this is a very good meta-analysis of the data. The headline figures would suggest that the air enema is the way forward, not liquid enema, but you have to look under the bonnet a bit and see that as long as you pair your reduction method with the right imaging modality, they're equally good. Ultrasound paired with liquid reduction works as well as air reduction with either method of monitoring. This is a nice recent paper in pediatric radiology looking at the use of a balloon. Now, we're very much non-balloon users at GOSH. We've always been told you can increase your risk of perforation, although the evidence base of that has not been strong until this paper. And this was a retrospective study, and clearly about half the radiologists in this institution were using a balloon and half weren't. What they showed, the raw figures would suggest that you had a slightly lower failure rate with the balloon, but a higher perforation rate. But if you sub-analyze by age, all the perforations were in the younger children. And they produced these nice charts suggesting that essentially you can safely use a balloon over the age of 1 in the rectum with an increase in your reduction rate as a result. So I think I might start doing that. I haven't yet. When you're using screening for intussusception reduction, you must screen fairly continuously because you can't afford to miss perforation for anything other than a second or two because of the potential for a tension in the peritoneum, which means you might think the dose is high. And certainly when the first paper looking at the dose recorded a moderately high dose of around 2 millisieverts as the average dose from an intussusception reduction. But on modern equipment, particularly with pulse fluoroscopy, we are talking now in the sub-millisievert range for even very long examinations, which I think is acceptable. One approach that I don't think is tried often enough is if you fail with your first reduction is to try again after a short delay. And a couple of papers have shown success rates of over 50% on delayed repeat enemas up to 3 hours after the initial enema. And it's definitely worth a go. We find it hard to persuade our surgeons to hold off operating, so we only do this occasionally. It's perfectly reasonable to do it systematically. And if an intussusception comes back, the question is often, well, is that an indication to go straight to surgery or not? Well, actually, recurrent intussusceptions are more likely to go back than first-time presentations, partly because you're probably seeing them much sooner, and partly because you've already reduced them once. So you can expect an over 90% success rate. The problem is what happens if they keep coming back. And what's interesting about this is this paper showed that you will continue to reduce them, but the more times they recur, both the easier they are to reduce and the more likely they are to keep recurring. So after a third recurrence, yes, you'll get it back. Yes, it will also recur again, and so should have another approach. I don't want to go over these points. I'll leave them up very briefly so you can speed read, because the big one is here, appendicitis. Now, this is a different story. Ultrasound is not the perfect test for appendicitis, and you'll see particularly, generally, low sensitivity figures for appendicitis. The low sensitivity is largely driven by scans where the appendix is not visualized. And if you only look at the scans where appendix is visualized, ultrasound performs pretty well. So, one of the key questions is how do you improve your visualization rate? And we'll talk about these other points as we go along. So, the gold standard paper is from Thomas Cundy's group in Australia looking at ultrasound. And this was a study of over 3,000 children. They managed to see the appendix in an astonishing 92% of cases. And you read through this paper thinking, well, what's their secret? And there is no magic bullet here. It's experience, time and patience, dedication, trying lots of different things. You've got to give some time, and you've got to have a determination that you will find the appendix. In terms of more specific things, this was a nice paper, this is both adults and children, where they use different patient positions. You start with a supine view, you turn the patient LPO and scan in the coronal plane, trying to pick up the retrocecal appendix. And then you put them back on their back. And I've started doing this, and it does kind of work. And often it's the second look where the appendix will suddenly appear. But it's just this really trying lots of different things. If you're determined, you can improve your visualization rate. In this paper, they went up from a fairly low 35% visualization to 60%. Another thing you can do to augment your compression is to also add some compression from the back. And this was a paper where they had a much higher visualization rate, but in those they didn't visualize, in 2/3 of cases, adding the extra hand at the back helped it to be seen. How do you diagnose appendicitis once you've seen the appendix? There's a traditional criterion of a cutoff of the mean outer diameter of the appendix of 6 millimeters. That, I think, is too low, and I've seen several cases where a normal appendix has been 6 to 7 millimeters. This paper by Goldin looked at different criteria. They used a higher cutoff of 7.5 or 6 to 7.5 with secondary signs, and that improved the performance of the test. But actually their best criterion was 7 millimeters or a wall thickness over 1.7 millimeters, which worked very well. In terms of the secondary signs you can look at, there are lots of them. There you can see, sometimes you'll see the omentum wrapping around the injured appendix without seeing the appendix itself. There may well be free fluid or a localized fluid collection. You may see bowel dilatation, hyperemia, bowel wall thickening, appendiculitis, and so on and so on and so on. There are lots of things that you can look at. If you can't see the appendix but you can see secondary signs, how useful is that? Well, it's not as useful as you might think, with ultrasound at least. This is quite interesting from a statistical point of view, because the specificity here is high, but the positive predictive value is low. It normally goes the other way. But the reason for this is that if you can't see the appendix, there's a very good chance it's not abnormal. So the secondary signs almost become null. Something similar results in this paper using MRI and ultrasound. And I'll skip over this one, because it's not so interesting. It highlights a really important point, that if you don't see the appendix, it's probably all right, much more likely to be all right. This is some summary data showing that of those with appendicitis, only 15% are not seen. When you see the appendix about half of them are going to be appendicitis positive. So that leads to the question of, well, is a non-visualized appendix basically the same as a normal scan? Can you classify them as that? Well, not on its own, but you only need to add in a smidgen of clinical information to make that actually a useful approach. If the white count's normal and you can't find the appendix, the likelihood of appendicitis is very low. And that would be a reasonable way to step forward. You can go a bit beyond that and look at a clinical appendicitis score, for example, with showing a similar effect. If you've got a low clinical suspicion, a non-visualized appendix, it's probably almost certainly not appendicitis. I think I'll skip that one. In terms of the blood tests, this is an interesting new development, and I think we might see this enter various aspects of acute medicine. There's this chemical called pentraxin 3. Now, the pentraxins, I only just learnt about, are a group of chemicals that include CRP, but CRP is made mostly by the liver as a systemic inflammatory response marker. Pentraxin 3 is made at the site of inflammation, so it's a more acute and more sensitive marker of inflammation. And the performance in this study from Turkey for detecting appendicitis, you see the bottom figure here, get the mouse working, sensitivities and specificities as good as almost any imaging test. So watch this space. I think this could be quite an exciting development for A&E departments the world over. If ultrasound fails, you may be asked to do some kind of cross-sectional imaging. CT obviously has a great track record for diagnosing appendicitis, and I don't want to talk about it too much. But there's a massive explosion in interest in using MRI for appendicitis, and there's lots of data that it's actually very good and can be done relatively simply, particularly in the older children over the age of 5. In fact, there have been so many recent papers that has been the subject of a meta-analysis giving some very impressive sensitivity and specificity figures up near 100%. And this paper recently by Dibble in radiology came with an editorial from Rick Van Rijn saying this is the end of history from the point of view of appendicitis. This is the way forward. Ultrasound first, and in clinically equivocal cases with a negative ultrasound, an MRI. I want to talk briefly then about so-called complicated appendicitis, because I think this area is desperately confusing. And I think surgeons seem to have a sort of rather patchy approach to this, and that means they have a patchy approach to the imaging. Part of the problem here, I think, is terminology. I was always taught about appendix masses growing up, but people talk about them less. But an appendix mass is essentially a contained perforation that may be solid, a sort of solid mass of matted bowel loops and appendiceal tissue, or an abscess where it's predominantly liquid. This was a fairly recent paper in a great surgical journal called The Surgeon, describing an approach to the appendix mass. It's a horribly complicated flowchart, but essentially an operation isn't necessary if the person gets better with antibiotics. If there's an abscess, which they defined as more than 5 centimeters of fluid, it should be drained, ideally percutaneously. But this is the problem when you get these different flavors of complicated appendicitis. Well, what does the surgeon do with them? And I can't seem to understand a consensus on this. There's a trend for treating simple appendicitis with just antibiotics, and some don't distinguish between a simple appendicitis or even a severe appendicitis that hasn't perforated, and that only the perforated appendix needs to go to theatre. But then others will take the view that the perforated appendix needs antibiotics, because that will then develop into an appendix mass and may or may not need a delayed appendicectomy. You can perhaps just save the appendicectomy for those about to perforate. I think this is confusing. I don't know what your local surgeons are like. Try and have conversations with them about what they think should be done. Part of the problem as well is that we don't have a particularly good track record of subcategorizing appendicitis with imaging. This is a summary of some of the ultrasound findings showing actually for detecting perforation with ultrasound, we seem to have a pretty poor sensitivity, albeit we do have a good specificity. I would highlight in here the sign that the loss of the echogenic submucosal layer on the inner side of the appendix, I think, is a useful sign that we should get in the habit of looking at when we look at appendices. Certainly when we see a big collection around the tip of the appendix, that's straightforward, but a lot of perforations, early perforations, may not have that. Likewise for CT, this shows a sort of variation in definitions and approaches. If you look at the literature, you see sensitivities as low as 7% and as high as 96%. So make of that what you will. Again, there's a similar sign to the loss of the echogenic submucosal layer on CT is a loss of focal enhancement in the appendiceal wall. That's a sign of appendix that's necrotic and about to perforate, and that's a good sign, it seems. Interestingly, this was a study that looked with pathologists at perforations as the gold standard, and the surgeon sensitivity for appendicitis was very poor as well. So they can't actually see an appendicitis by looking at it with the naked eye. What hope do we have? In fact, there has been one paper suggesting that MRI is the king of this, but I'm not sure about that. So this just to highlight the confusion, there's a couple of recent papers. In this paper from Ohio, described complicated appendicitis as where there was a perforation or a phlegmon or an abscess, an appendix mass or a perforation. And the significance of this from their point of view was that these patients should not just have antibiotics, but will need some kind of surgical intervention at some point. They included gangrenous appendicitis as simple appendicitis. And they showed that ultrasound, again, poor sensitivity, good specificity, as we've just shown. This paper, though, also from recently, defined a complicated appendicitis as one where there was a perforation or a gangrenous appendix. So it's a different category, and that these patients should go straight to theatre and not have antibiotics. What is interesting about this paper is the power of the loss of the submucosal echogenic layer seemed to be very, very strong as a predictor of appendicitis, with a massive odds ratio of 700. I've never seen one that high. So I think that's a useful sign, potentially. This is an example that we saw recently. This is a very fluid-filled appendix, surrounded, very thick-walled. There's echogenic omentum, some lymph nodes, and you can see patchy loss of the submucosal layer, had an appendicectomy, but developed a big collection afterwards. So once you see that sign, you know, oh, this is going to be not a straightforward appendicectomy. Finally, on appendicitis, the differential diagnosis, what else might you find? There's very little on this in the literature, and that's what my focus is today. Adnexal pathology in girls is obviously a common thing, and if you're dealing with right iliac fossa pain in a girl, you obviously need to look at the ovaries particularly. Ultrasound detects these with less frequency than MR. MR seems to be the king, and that's a good reason. MR is very good at ovarian pathology and looking at the ovaries in general, better than CT, and depending on your views, it can be better than ultrasound. So that may be another reason why MR is a good approach to these conditions. And similar results for other types of bowel pathology as well. Mesenteric adenitis, well, what even is that? Let's just not dwell on that. Okay, that's my summary slide for appendicitis. 3, 2, 1. Look at that, perfect timing. Thank you.